Yeah, that is the primary issue. Is it's staffing. It's not kiddos. They're struggling to keep enough staff in. But my guess is you're going to see several that will hold maybe the first week to 2 weeks following the holiday break, and that's when many of them will end their semester, and you'll begin to see either hybrid models for high school and middle, and your elementary kids will come back face to face, or they'll bring their kiddos back. But to keep the social distancing, those families that chose the virtual model will remain in that, so they can keep class sizes as such to promote that idea. Yeah. So that's what I'm hearing.
One of my youngest daughter is taught in Olathe and works for the state of Kansas, and so she's the science coordinator for K through 12. And there's districts out in western Kansas that, they've got 2 teachers for the whole school now. It's just a disaster.
Well, we have a family farm out in Buckland, which is near Dodge City, and those cities that have meat packing plants are just devastated.
Oh.
If COVID is, well, you can read the map.
Yeah,
it's and it's been that way for a long time. Whether it's Garden City, whether it's Dodge City, whether it's any of those large meat packing plants out there, and beyond that, it's the same in Southwest and Southeast Missouri. Their internet connectivity is lousy. They don't have it. Yeah. It's non-existent.
I found some interesting data about that when I don't remember why I was looking into it, but when the government looks at internet connectivity and says how many households have high-speed internet, I think the number is 5,000. They look at this little block of 5,000 households, and if one of them has high-speed internet, then that neighborhood has high-speed internet. So there may be 4,999 households that don't, but as far as the statistics go, they've got broadband. It's all good.
Well, I can tell you, it's not happening in Southeast and Southwest Missouri either, where it's just not. You don't have capacity.
Yeah, the rural areas are really paying a big price without that asset, and so. Why don't we go ahead? I believe it's 6:03, and why don't we go ahead and call the meeting to order? And then let's go ahead and read the minutes from last meeting, and we'll let you review those shortly.
Move to approve.
Second.
As presented.
Jason seconds if you need it.
Yes. Okay. All in favor of accepting the minutes as printed, say aye.
Aye.
Aye. Aye.
Aye.
All opposed, nay. Okay. All right. Well, our primary course of the evening is to go over the PowerPoint that Dr. Terry Morris has put together regarding the questions presented to us by the council for our input. And so, Terry, let's turn the meeting over to you and hear what you've put together and help you with any kind of thoughts that some of the members of the Board of Health might have to share with you.
Yeah, this was an interesting event. I'm going to just share my desktop here. It was an interesting task because what we were asked to comment on was not really straightforward. So this is basically, I'm just going to run through it, and obviously I'll present it more formally when the time comes. This is the city's format, so hopefully it's all going to run appropriately. And it's report from the Advisory Board of Health, and to the City Council planning. Basically, it's about COVID-19, and it's scheduled for the 14th. For the people who aren't in tune with what goes on, I'm going to explain what the Advisory Board of Health is. Basically, it's an advisory board of the city manager, the Department of Health, and the City Council on matters pertaining to public health, and that's what we're supposed to do. Currently, it's made up of 1 dentist, 3 physicians, 1 veterinarian, 2 nurses. I didn't know what to call John, so I called him an educator, and I mean that honorably. 1 community member with medical experience, and then we have 1 open position unless we fill that before the meeting. Local health departments' core services are basically to deal with adult and childhood immunizations, communicable disease control, outreach and education, epidemiology and surveillance, and that's really what we're dealing with the COVID pandemic. The advisory board has been asked by the council to examine 4 different things: factors related to comprehensive community health, to report on the general economic and health impacts of the COVID pandemic, the future outlook of health limitations in the community, and I'm assuming they want us to comment on the availability of broad community input for decision making. So we'll start off with factors related to comprehensive community health. This is a 60-second update from today from Johns Hopkins. This will be the one that will be on the presentation on the 14th, because I won't have the ability to upload the 14th data. And it's pretty straightforward. And this is a graph also from Johns Hopkins that shows where we are as of this morning in relationship to the other countries of the world. And the United States is the green line, so you can see that we definitely have a significant problem here. This is our daily Kansas City regional snapshot from this morning. The thing to take away from it is basically just there's a general increase. And what worries me the most is the increase in hospitalizations. This is the graph that shows the hospitalizations daily. It's a 7-day rolling average for Eastern Jackson County. So that's basically Independence, Blue Springs, Lee Summit, excluding Kansas City Mo. And as of the 7th, which is the last data we have, we were averaging 33 new patients from our community per day. That's obviously a concern. I want to just speak briefly about COVID-19 transmission. Who infects who? The term.
Dr. Morris?
Yes.
Do you anticipate somebody will challenge you on the methodologies for identifying? I just want to try to be preemptive, or I don't know if any of the council members will. Do you anticipate that?
I do, because I unfortunately watch the news, so I know what goes on. I'm happy to answer any questions that they have about where this data came from. Almost every slide, I've included the resource that it came from in the bottom right, so that they know, A, I'm not making it up, and I'm happy to comment. I honestly had somebody, I'm trying to think of where it was, that asked me if I thought that the numbers about COVID deaths were accurate. And my response was, everybody who gets reported as being dead is actually dead. And I've actually talked with both the states of Kansas and the state of Missouri personally. And having filled out a few death certificates in my day, I know how that happens. And you don't just make up that they died from COVID. If they died from COVID, that was the number one cause of death. Their diabetes, their heart disease, their prostate cancer, or whatever goes on the end of the sheet. But if they died from a heart attack but had COVID, their cause of death is a heart attack, not COVID. And although people love to say hospitals are doing that wrong, they're not.
Right. Thank you.
Yep. So when you look at who gets infected by who, we look at something called the basic reproduction number, and it's usually about 3, meaning if an average person gets infected with COVID, they generally will spread it to 3 other people, maybe their spouse, maybe the person sitting next to them at work. That's on the average. The problem we have are super spreading events, and that means a single infected person spreads the virus to more than 10 people. There's numerous reasons why that can occur, but it seems to play an outside role in the United States. These really large super spreading events between 10 to 100 people infected are more common than we ever anticipated were going to happen. This was a quote from last week's Scientific American. As few as 10% of infected people may drive a whopping 80% of the cases in specific sorts of situations. And the CDC estimates that 40% of transmission occurs before the infected person has any symptoms. So this isn't somebody that feels sick and goes to work even though they felt sick. These are people that have no clue that they're sick, that are transmitting this disease. So what are the risk factors to continue to consider? You have to look at how many people do we have in a space? How big is that space and how close is the contact? How long a time is the exposure? Is the location inside or outside? Are the surfaces that they come in touch with high touch? Are they surfaces that everybody touches, doorknobs, light switches? And is it within an area where it's already experiencing a high number of cases? And then a term that was new to me, which is called COVIDosity, which is how likely is the compliance? If you go into a restaurant, how likely is it that people have on masks? How likely is it they're wearing their masks properly? How likely is it they're washing their hands after they sneeze? This is a local case report. I don't know if I'll mention it, but it actually was my doctor. There was a family gathering to celebrate an 8th birthday party in the family. He didn't want to go. His wife made him. That's the way it works. There were 13 adults, 2 teens, and 7 children. 2 adults had actually had negative tests before a gathering. They came in from out of state. No one had any COVID symptoms whatsoever. They had appropriate mask wearing during the gathering. They only took their masks off when they ate and drank. Kind of marginal social distancing because it was in somebody's house. So you have marginal social distancing. Every last one of them developed COVID. 1 required hospitalization with severe symptoms, ICU care, mechanical breathing assistance. He was released from the hospital after about 10 to 14 days. That was about 3 weeks ago. He's still on oxygen. We still are uncertain of the long-term effects that this man will suffer. This is a nice graph that comes from an organization called Information is Beautiful. And it basically breaks down activities by what's the risk. If you're going to do takeout food, you're going to go play golf, you're going to use your friend's bathroom, the risks are reasonably small. If you're going to go to a buffet or you're going to go to church and sing, your risk is pretty high of transmitting that disease. For a report on general economic and health impacts, obviously there's been significant impact on service industries, restaurants, bars, amusement parks, hotels are all suffering greatly. I think analysis of pandemic economics is beyond the scope of purpose of the Advisory Board of Health. And I think if the council needs additional information, they have resources to seek that from. Hopefully they all were able to attend this online conference that went on Tuesday, which was actually quite good. where the chief medical officers of all the hospitals in the region sat down with the Civic Council of Greater Kansas City and business leaders and talked about the community update. From a healthcare economic impact, hospital revenues are mixed. Large hospital chains are holding their own. A few of them are actually making money. Hospitals, particularly in rural areas, are closing their doors. Office-based physician and dental practices revenues are significantly decreased. My friends that are practicing that are still independent are operating at about 50% of their usual patient load. Physicians and nurses are retiring in record numbers. Physician offices are closing. Somewhere between 8 to 10% of doctors' offices that are individually owned will be closed by the end of the pandemic. Health impacts, there's been a huge impact in mental health issues, depression, anxiety, child abuse, domestic violence, loneliness, and grief. There's been a decrease in acute emergency care. Patients are not seeking care for acute chest pain. They're not seeking care for symptoms of stroke. They're not seeking care if they may have a diabetic crisis. And obviously, delayed outcomes or delayed diagnosis produces poor outcomes, or people that are dying at home or that come in very late in the course of their illness. For office-based care, we're seeing a decrease in immunizations. We're seeing patients failing to follow up on their diabetes, failing to follow up on their hypertension. They're not getting their mammograms. They're not getting their colon cancer screenings. They have delayed diagnosis of new problems. It's like, well, I don't really want to go to the doctor. I'll wait and see what happens with this. And again, this is going to be harmful in the long run. From a pediatric standpoint, we're seeing a decrease in routine immunizations. And the interesting thing about this is that this may increase the risk of secondary epidemics. We're also seeing a lack of preventative care. There's an alarming increase in weight gain. We're seeing decrease in physical activity, an increase in depression and anxiety, and issues with food insecurity, particularly in younger children where their meal at school may be their main meal of the day. So hopefully we can get them back into school soon. Hospital care, we're seeing an almost never seen before provider fatigue and shortages. It's not that we don't have beds, we don't have nurses and doctors to take care of the patients in those beds. So we're approaching an unavailability of beds. I think Daryl said last week 95% of the beds in Kansas City that were staffed were full. It's making providers make decisions on who gets care. We've got a 75-year-old grandpa. We've got a 35-year-old mother of two. Somebody's going to get care. It's probably going to be the 35-year-old mother of two. Sick patients are being sent home on oxygen that may have previously stayed in the hospital, but we've got to get them home to make room for sicker patients. And we're starting to see a slight but definite increase in the death rate. So what's the future outlook of health limitations in the community? The answer is we don't know. There's been lots of different thoughts on what the trajectory of this outbreak will be, but it really depends on how we manage it. The manufacture and distribution of vaccine has got profound challenges. Every day on the news you hear something and the next day they say, well, they're not really going to do that. Another problem is that a second dose is required. So if you get 100,000 doses in this community, do you give 50,000 of them and hold the other 50,000 because in a month they've got to come back and get their second dose? This is also a new vaccine technology. We've never had a vaccine formulated from messenger RNA before. The data looks pretty good. One of the reasons that we've been able to produce this vaccine so quickly is because it's an entirely new technology. But we only have people that are 3 or 4 months out on the vaccine, so we don't know how this is going to work and how long it's going to work. We've already had cases of people having COVID for their second time. It also depends on the willingness of the public to be vaccinated. This was a slide from Pew Research Center last week. Back in May, about 72% of Americans said that they definitely or probably would get the vaccine. Then we got politics involved, and in September, that was down to about 50%. This study suggested about 60%, although I saw one yesterday that said about 52% of people would get the vaccine. Of those who wouldn't, some of them are, I definitely won't, and the other one is, maybe after a couple million people get the vaccine, I'll consider it. The problem with that is that our ability to get rid of COVID depends on herd immunity. For measles, it takes 95% of the population to be immune to measles in order for measles to disappear. For polio, it takes about 80%. We don't know what it's going to take for COVID. We don't know if we're going to have 80% of our population vaccinated or immune to COVID. We don't know if we're going to have 100%. That's just going to play out over time. It's also going to depend on a willingness of the community to continue preservative measures. When the vaccine's out there, people get a false sense of security. Oh, well, people are getting vaccinated. I don't need to wear my mask anymore. And that's just not true. As far as broad community input for decision making, when I started this slide, we hadn't established we hadn't gotten our city health department back. So I was going to talk about who to talk to at the county level and how to find your county legislature. Now that the City of Independence has its own health department, basically the people to give input to is the city council. And that's basically the presentation that I had to give, and I'm happy to add things. I can't add slides, but I can definitely add comments or not talk so much if that's better.
I didn't see anything that looked like there needed to be any correction or improvement on. I thought you did a really good job, and I think you covered the bases very well, and the subject of the economic issues, and then just the overall story behind the COVID pandemic that we've been in for coming up on a year. Hard to believe that this it's not that far off that we're closing in on that much time. So at this point, any other thoughts or comments that anybody would like to share?
No, thank you for doing this. Well done.
Yeah, it's just an interesting thing because I don't really know what they want to know. And like I said, we're the Board of Health Advisory, and can't really talk about what percentages of businesses are surviving or not surviving, and what role government stimuluses play. And I mean, it was hard to get this much information in that little time. I don't know exactly how long that was, but hopefully not much over 15.
Well, you held my attention, and I think that it went by really well as far as just the information was interesting and well presented. So I think that City Council will have some questions for you, and it'll be interesting to see how quick you are on your feet, how fast you are.
And I'm definitely going to let them know that my answers from that standpoint are my answers and not the advisory board's answers. I mean, if they want to give us questions and all of us can come up with a group answer, that's fine. But when they ask me what I think about how much of these diagnoses are made up or whatever, it's going to have to be my answer, and I'll make sure they know that I'm not answering for you.
Hey, Jason White here.
Go ahead, Jason.
Thank you very much for doing this. I really think a huge part of this is not only the message, which I like the completeness, but the messenger. So many people in town know you and respect you as a local physician. And when you look at some of the surveys of the divisiveness in our country at this time about who do people trust, and their personal physician is still very well trusted, and you fill that role. So I think you have the opportunity to convey information to the council, but more importantly, in my opinion, to the community about this issue, because they're certainly bombarded by volumes of really bad information off the internet and confusion in the media and the professionals trying to react to an evolving and changing situation. That means they have evolving and changing responses that looks like it's confusion. And maybe it is, but I think most of it's just reacting to the changing environment. So I think I appreciate the fact you're willing to do this, because I think the messenger is just as critical as the message. So I weigh in and say thank you.
Well, part of the problem is that the data that I put in this morning may not be true on next Monday. In fact, I read a study last night that depressed the heck out of my wife that suggests that people who are immune to COVID may still be able to spread COVID, because you may have been exposed, you have COVID in your nose, you're not sick from COVID, but you're exhaling COVID on other people. And so that's where that concept of continuing to wear a mask after you've been immunized is important. And that's the real challenge in our country, is people are tired of that and they don't want to do that. And they can't comprehend that concept of herd immunity, how many people it takes to be immune to a disease before you don't have to worry about that disease any longer.
So in terms of this particular point you just made regarding having immunity but still carrying and spreading, is that do they have any numbers on how significant that population may be?
No, when you look at these studies, the phase 3 trials have been like 40,000 people in the phase 3 trial, and that means 20,000 of them got the vaccine. So you really don't have that many people that have gotten the vaccine yet. So side effects from the vaccine will show up. And after we've given several million doses, then there'll be the ability to say, what are the side effects? What are the risks? How effective is it? You come in and you get your shot, and then 4 weeks later, you come back in and get your second shot. And then hopefully you're immune. All of us know somebody that got a flu shot and still got the flu. Happened to my daughter last year. She wasn't as sick as she could have been, but she still got the flu. And it's going to be a challenge. And I wish it was different.
Don't we all?
Yeah.
Okay. Well, Christina, what do you think?
I think it's just fine, and I have already uploaded it, and it should be ready to go. We'll work with Dr. Morris to make sure that hopefully that everything's going to function, because we'll be on a slightly different online format. As you and I discussed earlier this week, the city's still reeling a little bit from the ransomware attack that happened this last weekend. So we're struggling, but it'll be fine. We will find a way to make it work, as we always have.
Yes, we have that pioneer spirit still, I think, even in this modern day and time. Well, if there are no other any other thoughts or comments that anybody would like to make before we call this meeting to an end.
Yeah,
hey, Dr. Ruckman, Daryl Nelson. Sorry, you texted Christine. I had some connection issues and was off a bit, but I replied earlier to Terry's email. Awesome presentation. I heard the beginning and the latter part here, and I offered him a job. And just so all of you know, we're really blessed. So it's really good stuff, and it's right up there with the stuff we see, put together by a lot of entities that have access to a lot more support and resources than Terry does. So I think the message is spot on from my perspective. I'm fully supportive, and and hopeful that it will go well. And then I didn't know if you wanted just a minute or two on kind of what's going on in the community and at the hospital, but if you're ready to break, that's fine too.
No,
No,
I definitely love to know that.
I would like to hear it
Yeah.
as well. So,
Yeah, well, we saw a substantial uptick probably a couple of weeks ago. Nothing unique, and just the overall numbers from what you've seen in the public media. It ultimately overcapacity Research Medical Center, which is, all of you probably recall, had been doing centralized COVID care for all of the 6 metro HCA hospitals. So we got asked to bring COVID care back online at Centerpoint. We're in our 3rd week now. We brought up 12 beds, filled them essentially overnight at that point, opened another unit, filled that up, and basically within about 4 or 5 working days, we've gone from, essentially 0 or 1 up to a number that's been consistently between 26 and 34, 35, I would say, on any given day. We had 33 in the house today. Throughout that time, research has been running between 105 and 130. So those numbers had consistently, prior to about 3 weeks ago, been in the 70, 75, 80 range for our whole system. So a substantial uptick. The other health systems are feeling the same. We've been working with Mark and some other institutions to clarify what bed capacity really looks like, just like we talk about in our meeting with the data we get to see. There's a lot of inconsistencies in the citywide data, and it has to do with so many discordant reporting entities. But we are generally across the health system on any given day in the city bouncing between the 84, 85, and 93, 94% capacity of staffed beds. And when you get at 95%, you start getting into contingency planning. And then once you move, obviously, past 100%, you're starting to dabble on some of your crisis intervention plans. So we've been collaborating with the health systems across the city with some anticipatory planning around what we might do there as far as reallocating resources, starting to readdress things like you heard us address back in the spring as it relates to elective cases and repositioning subacute medical care that might be able to be managed other than an acute care hospital setting. So there are a series of daily meetings, as you can imagine, going on, just monitoring this literally throughout the day and evening hours to try to make sure we can maintain our availability. And, we very much don't want to be one of those communities that, we've unfortunately had to watch on the nightly news. So we're doing our best to anticipate during this kind of run-up phase and manage proactively and keep that availability as viable as possible. So I think we're anxiously waiting to see if some of the models that we're tracking are going to, be on or not. They've been a bit variable here. They did predict the run-up that we've seen pretty closely. There's some discordance in the models as we look to the latter half of December, and then on into January, but most of them show at least some continuation of the surge. So we're preparing accordingly. We did sign up with the state as a vaccination hospital, and we're registered on the Show Me Vax website. Anticipate potentially getting a vaccine either next week or the following week. There's some talk that the state's going to do some finagling with allocation depending upon the Pfizer versus Moderna production schedules. So we're thinking from some of the intel we're getting that we'll likely be in the Moderna program, which will probably be the following week. But it's unclear. As of late this afternoon, we had folks reaching out to the state board. There's a leader of the immunization arm and trying to get some clarifications. But we have all of our hospitals up and registered, and we're ready to vaccinate. We anticipate from our internal surveying, we have about 1,700 people that'll fall into the A1, A11 and 1.2 and 1.3 and 1.4, which is the primary group that we're expected to vaccinate as soon as it becomes available. So we've been spending a concurrently busy amount of time just planning to do that as well. So very active time. We've got obviously some provider fatigue. Our staff's holding up pretty well. We've been in the 20s consistently with staff out, either with positive COVID or at least symptoms that merit them not being at work. And that's a manageable number so far, but we'd certainly like to get started vaccinating as soon as we can. So happy to take any questions, but that's just a couple of minutes on kind of the state of the community and Centerpoint in particular.
So do you know which vaccine is going to be primarily in this area? I'm sure that they're going to, they're not going to overlap the vaccinations, are they, as far as the different sources or brands? Or
yeah, the plan is not to do that, and we think that those that are going to be Pfizer in the first phase have already been notified, and we've not been notified. So that's why we're thinking we may be Moderna, which will be the following week. But the intent is then to try to get all of the first phase healthcare workers that were obligated by prioritization to vaccinate, to try to get those done within the first 10 to 14 days after receiving the vaccine. There's a lot of nuances between the two about how they have to be stored and managed. So our plan is to aggressively vaccinate whichever we get. And then the intent is to try to keep each health system on schedules with the same brand so that you don't get into issues of you're not supposed to cross-vaccinate, and then obviously it just creates tracking nightmares if you end up trying to do both. But again, that all remains to be seen. Everybody's basically signed up in the system, and the decisions for allocation will be made through the distribution arm with the state and the federal government. So they told us just to be on point and ready to start as early as this coming Monday. So,
Terrell, this is Terry Morris. Do you have pretty good buy-in from your staff? I've read a couple obtuse articles about some hesitancy on the part of medical staffs to sign in for immunization. And I know with flu, we always had a cadre of folks who walked around with masks on from late August until June because they wouldn't get a flu shot. Yep.
Well, oddly, Terry, it's just continuing to get more accepted. So the industry surveys a month ago said 60% of the physicians and 40% of the nurses would partake. We surveyed about 2.5 or 3 weeks ago. We got 73% of our hospital staff in favor of planning to take the vaccination. And then we surveyed our medical staff independently just last week, and 96% of our medical staff plan to take. So that had gone up notably from what the industry surveys had been suggesting. So I think what we think is probably going to happen is that it'll be a strong majority through the first round. We know some have already told us they want to wait and watch the first round and see, and then they think they'll likely want to partake, but maybe not the first. So I think we're going to have higher than expected rates in comparison to what we see. Because frankly, we still wrestle that with the flu vaccine. 70-75% across the house is a pretty good flu vaccination, honestly, even after all this time.
Thank you.
Yep. So, Dr. Ruckman, I think that's all I have. I appreciate the support from the community. Just want you to know, got folks working hard and trying to do their best. I just met with our hospitalists who are literally right at the point of the tip of the sword, as our ER physicians and some others are. And, they're holding up, but, obviously just the kind of fear of the unknown, if this thing continues to creep up more, is taking a bit of a toll on everybody. So
I did have a question that finally came back to me regarding the vaccination. The ones that have multiple doses that are needed, when you vaccinate somebody, are you going to purposely hold back the second vial for that particular person's second immunization shot, or are you going to just hope that the supply keeps coming and that their second dose will be available when when the time comes around, and you won't necessarily hold anything back.
Yeah, the latter. We're obligated to go ahead and vaccinate first round on everything we receive. And then there is a commitment that if we've been shipped what we request or some percentage of that, that's being shipped knowing that 3 to 4 weeks later that there'll be the availability of that same vaccine to do the second dose. So we're expected to vaccinate all of it and have to report real time in the Show Me Vax database as we vaccinate. They've kind of told us if you're not going through it, then you'll probably get your allocations decreased. So their expectation is for us to get it done, and then they've committed us that we would have subsequent doses shipped to us.
Okay, great. That's good news. Because in most vaccination situations, when you have a second dose, how significant is the second dose depending on the time frame after the first one?
Yeah, so I think Terry was referring to the current windows are 21 and 28 days for the Pfizer and Moderna, or Moderna and Pfizer vaccines. And so the expectation is that we try to keep that separation as close as possible. It's a minimum of those days in between. So anytime after 21 or 28 days, then we can give the second dose. And then there are some notes about some increasing side effects with the second dose, kind of malaise, fatigue, and low-grade fever. So we're also planning to stagger how we vaccinate within a particular service line or department or specialty, so we wouldn't inadvertently kind of take too many people out if they did have a run of side effects. Not serious, but just some reported hard enough that you have a hard time to work a full shift.
It's nice that Britain's a couple weeks ahead of us so we can watch them and see what's going on.
Yeah, we can let them have the first round, and let's hope that it all goes well for them and that the issues are going to be very small to limited. Well, at this point, any other comments?
Dr. Ruckman?
Yes.
Jason White. Could Christina give us a couple of moments on what's going on with standing up the new health department and what that means for the community and us?
Sure, that'd be great. Christina?
Yes, so as I shared earlier this week, the city late last week received news from the state that we are again a local public health agency. The honest answer is this is going to take months to rebuild. We are actively working on it. This afternoon, a new order was released that is very similar to other orders in the area, but as a local public health authority, we wanted to make sure that there was an order out there and that everyone was covered to continue that mask mandate and some of those other restrictions for social distancing. But we are going to continue working. It's going to take months. This initial recognition did not include funding. Because they are in the middle of a budget year already with the state. So funding will start this next summer. So we are working to get all the people in place and get everything done the right way to make sure that we have everything ready to go when that funding's there. A lot of the stuff we expect we'll be able to start earlier than this summer, and we're working hard to make that happen. It has not been easy with the ransomware also happening at the same time for us to all communicate that, but we're again trying to make it work.
So Christina, help me, because are there essential functions that have to be a part of your health department that you have to stand up first, and then you have secondary functions? I have no idea what that, and that may not be for this discussion here, but I would be, what do you have to stand up first, and what's priority, and from a health department standpoint?
Well, I mean, anybody who's in public health knows there's the 3 core functions, and there's 10 essential services in public health. I'm not going to bore you with the answers to those that every public health student has to learn and memorize, but I will tell you that there are functions and services that the state and the CDC consider absolutely essential and that we will have to provide. When it comes down in a nutshell, especially right now, I mean, obviously we're in the midst of a pandemic, and getting those communicable disease people back and up and running in order to ensure contact tracing and vaccination clinics should we need them, and all the other pieces. That's one of my main focuses right now, is making sure that communicable disease is stood back up. So we're working with our partners. We're working with the county, we're working with the state to try to make sure that this transition happens so we can hit the ground running as quickly as we can.
I would add too, it's not just COVID.
No.
When you say communicable disease, it was previously 3 full-time people managing day-to-day communicable disease. So it's a lot to get up and running and to start over.
Well, those people were amazing. So, I mean, obviously.
They were.
So Christina, when, like from a school district standpoint, you know, we work daily with Jackson County Health Department. So at what point do we transition to start working with the city?
I do not have that exact answer with you. I can tell you we're trying to work that out. You know, I wish I had an exact answer for you. As soon as we know and we can work out that timeline for exactly how to do it, we will let you know. Right now, you know, the county received the funding in order to cover the City of Independence for that entire year. So it's the expectation that they'll be able to continue doing some of that work and continue working with the school district, and that we'll be able to slowly phase ourselves in because they're the ones with the funding to do it right now. Mm-hmm. And that we'll be able to get some funding in place and be able to take over some of those duties as we go. But it could be a while, I'm not gonna lie.
Okay, perfect. So any thought on perhaps maybe having flu vaccines next year?
I am wholeheartedly all about immunization clinics. So we will do everything in our power. I mean, that is my thought. I have to do the caveat that, you know, I am the acting health director right now. We are in the midst of a pandemic. So I will have to make sure we will do what we can, but I can't promise until we can get out of this.
Perfect. I understand that. Thank you.
Okay.
Christina, I do have one quick question. This is Terry Morris. Megan Lewis sent out an announcement today from the mayor and from you about new guidelines for restaurants and businesses. I didn't get it, but my wife did. She says, "Oh, what's going on with this?" And so is that a significant change from what we already had? It permitted bars and restaurants to serve food and drinks from 5 a.m. until 10 p.m. and it goes into effect in about 5 hours. So,
yeah, so it does go into effect at midnight or 12:01 tomorrow morning. It is not a significant change. One of the biggest changes is it goes from the curfew for food and drink establishments at 10 o'clock to the curfews now midnight. That is the biggest change. We have already had questions on social media about whether COVID goes away and starts hiding until midnight. I don't believe it does, but it is the time that was chosen.
Thank you.
All right. Hearing no other comments or consideration for discussion, let's go ahead and call this meeting, adjourn this meeting, and we'll see you next Monday at the, well, I guess it's going to be a virtual meeting, yeah. So we'll be getting, it'll be team meeting, I guess, or will it be Zoom or?
They don't use Teams or Zoom. I can't remember what it is. I will send out the information. I mean, the easiest way for the entire board to watch it is on YouTube. Whether you go through the city's website if it's up, or whether you just go straight to YouTube and search for the City of Independence, or watch it on City 7. Any of those ways should work just fine.
Okay, and yes, John? Oh, I thought you raised your hand. Okay.
Hey, Christina, I bought a mask that matched my bow tie so that I'd look good when I was there. Can I wear my mask anyway, even though it's virtual?
Yeah, I mean, I'm fine with that. If it looks good, go for it, rock it.
Very good, Terry. I'm looking forward to seeing this extraordinary mask.
Oh, yeah.
All right. Well, good night, everyone, and have a good evening. And we'll see some of you and anybody who wants to join in and support Terry. I would encourage you to do so. So between now and then, let's keep him in our thoughts, and we'll see how his comments are accepted and where we go from here. Good night.
Good night. Thank you.
You're welcome.